Hi, good morning, good afternoon, everyone. Thank you for joining our roundtable today. My name is Aaron Fulner with Invent Health. Welcome to our November roundtable. So today, our panel of experts will be discussing a seismic shift in the Medicare Advantage world, the transition from V24 risk adjustment model to the V28 version. I'm joined today by our CEO, Rohit Bardwaj, our Chief Product Officer, Siva Tunga, and our Principal and Healthcare Advisor, Mark Ishimatsu. So let's go ahead and jump right into the topic. Rohit, would you like to start us off?
Yeah, absolutely. Thank you, Aaron, for putting this together. I'm really excited to talk about some of the changes which are hitting our industry right now. And in particular, I see a significant impact due to version 24 to 28 shift that is going to be effective from January of next year. I would be curious to see what Siva and Mark's take is on the entire shift. But at the outset, I feel that health plans have to be ready for a new normal where they might have to be ready for a financial and operational impact due to this change. I do also see that more hierarchical codes, HCC categories have been added, and RAF rationalization with a reduced ICD coverage is also a part of the whole shift, right? So certain conditions like diabetes and mental disorders might be weighted in a different way. So health plans might have to work closely with providers going forward to accommodate the new business rules. But let's hear from our expert, Siva, right? What is his take? And I think he can take us a little bit deeper into the actual impact, and we can weigh in accordingly, Mark and I. Thank you, Aaron.
So again, as Rohit pointed out, V24 to V28 changes, we are dealing with these ones where the HCCs are getting shifted. And as we are analyzing, there are more and more granular impacts when it comes to the complexities, both for health plans and providers. One of the key noting point is where you're going to see is reducing your risk score mapping. Basically, the diagnosis codes, around 2,300 diagnosis codes, are reduced or excluded from a V28 mapping. That has direct impact in certain age groups or certain population, especially when we are dealing with newly enrolled Medicare population versus chronic and sick population. The mappings are going to be different. The biggest notable change where you look at is where people need to start understanding the impact is what we call constraining of the coefficients. Means the HCC score is same for certain HCC groups, especially diabetes and congestive heart failure. Regardless of their complexity, you might get the same HCC. So what it puts a lot of emphasis on addressing the utilization, improving the care management programs, etc. There are additional big changes which are primarily related to other groups like malnutrition, artificial device implants, where they're no longer mapped to an HCC, which is again critical in order to assess your care management and other programs as well. So where you need to look at, if you look at it by program or by disease categories, you will see a lot of impact on your vascular disease, metabolic diseases, heart diseases, diabetes, psychiatric diseases, and musculoskeletal diseases. So this is some of the areas where we work closely with health plans and providers to understand the impact.
Thank you, Siva. That was a great insight. Mark, so CMS obviously had a rationale for making these changes. Can you shed some light on this?
Yeah, this is an ongoing effort by CMS to make sure that the identification of chronic conditions is as accurate as it can be, and also that they adjust the reimbursement appropriately. So we see that on both ends. We see the changes in some of the HCCs, the addition, some removal, and also the realignment of the diagnosis codes across the different HCC categories. And then they've also then on the revenue side, they've made adjustments, obviously, with the risk factors now have changed. And I think these are going to have some pretty significant impacts across the industry. So both on identification and also on the revenue side. So this is an ongoing effort by CMS. This is a big one, but these kinds of changes are going to happen in the future, and I think clients need to be ready for these changes, and subsequently be able to kind of adjust as Rohit says, the new normal.
Gotcha. That was great. So Mark, let's move on. Sticking with you, let's talk a little bit about some insight on why this shift matters and what are some of the impacts.
Yeah, the shift matters a lot because there's been a lot of focus really on the changes and the subsequent revenue impacts, and because their expectation really of seeing, potentially as much as an 8% reduction in revenues under the V24 versus the V28. And there's been a lot of focus on that, and then obviously the plans have been reacting quite a bit to that in terms of how they're going to respond to this expected reduction in revenue. But I think also what plans need to really pay attention to is going to be the operational impacts on this. And there's both internal and external operational impacts that need to be addressed so that they can mitigate the impact of really what it'll be look like from reduced revenue. And also look for opportunities to really take advantage of it as well, because there are some areas that I think do offer some opportunity for plans. But I think that the real impacts are going to be operational, and I think with externally with their provider networks in education, internally with their own kind of disease management and care management programs, make sure they're properly aligned to these new categories and definitions. And I think the plans that do that well, I think we'll be able to kind of become a market leader, particularly early on. But and those that don't pay attention to this, I think, are going to struggle over the next couple of years.
Thanks, Mark. I appreciate that. Rohit, would you like to weigh in?
Yeah, no, I think great insights from Mark and Siva on this, right? I mean, I feel this is a domino effect, and this is not going to stop, right? Because a lot of systems and a lot of applications, they worked in tandem. That includes payers and providers. They are the most impacted of this change, right? And the providers are already very burdened with existing workload that they have, and on tops they would have to now get used to this new normal, like I say, of code versus not what to code or not to code, right? With the version 28 versus version 24. And I am expecting this will lead to a lot of coding errors and inaccuracy at member diagnosis level, which ultimately leads to inaccurate risk scores and declining RAFs, right? So internal business logic readiness for these health plans or providers should be least of their concern. They should work with technology partners which have a robust system to handle these changes from a technological and business rules perspective. But they should rather focus on getting this relationship right between providers and payers, how to reduce the workload, how to educate them through provider education, how then get them used to the new normal. I think that should be the most important concern for both providers and payers.
Excellent insight. Thank you, Rohit. So to close out our roundtable, let's take a closer look and discuss what MAOs need to understand and implement at a high level to navigate the shift successfully. Right? It appears that there is clearly, financial impacts expected from the change to 100% use of V28, and this should trigger, additional strategic, analytic, operational changes that plans need to address. So, Siva, would you like to give some more insight into this?
Yes, thanks, Aaron. So the first thing what it needs to be looked at is dual coding complexity, right? In terms of health plans, more from health plan perspective as well as from provider education perspective. How do you enable your systems to maintain a dual coding system? This is not just one time. We have seen these models running in the past with V21 and previously RAPS EDPS blended models. Now we are talking V24, V28. You need to think about this more futuristic to say any model being implemented, how you are able to handle that, and do you have the processes to be able to adjust to those and quickly work on those both coding versions. You need to reduce errors in this processing because your systems have to be enabled and worked on those changes. The next important one is documentation requirements, your coding guidelines. If you are talking about HCC coding versus regular coding, emphasizing that on the provider training. Core concept of meet or monitor, evaluation, assessment, and treatment does not change. But what it changes is your workflows. What charts are you reviewing? What charts are you need to look at from a prospectively to document and make sure your providers are not doing that. More emphasis need to be on prospective review so that you are enabled as part of the process to train your provider groups and identify the common errors to reduce them. It impacts your care management strategies as we talk about, right? Because the complexity of certain conditions is changing, diabetes and as well as congestive heart failure and other musculoskeletal conditions. What it means is what you have aligned your care management teams on high priority and high stratified population, you might need to look at it from a different perspective altogether when you are analyzing this and looking at the utilization. Your care management workflows along with quality are aligned to the new way of capturing the chronic conditions and reporting them as well internally.
Thank you, Siva. Are there any other viewpoints on what payers need to do operationally regarding this shift?
Yeah, I think that the risk adjustment operations for payers really need to take the lead on this, because they're really internally for the payer side. They're the kind of should be where the subject matter experts are about these changes, and they need to be able to communicate these changes, the kind of what the changes are and how they're going to impact both as the provider partners and internal operations at the health plans. The risk adjustment operations really need to take the lead on this and to be able to kind of socialize this, because on the provider side particularly, they're going to need to understand why there's going to be some impact on their revenue as a result of some changes in risk scores. They need to understand where it's going to happen, how much they expected to happen, and that's going to be true across each of those different contracts that you have with provider groups. Internally, the understanding, again, as said, with care management particularly, needs to understand what these changes are, because it may very well change the kind of programs and the approaches and also the populations that they're really going to deal with and how they're going to deal with them. So both internal and external impacts, but risk adjustment should be taking the lead on it.
Thank you, Mark. Rohit?
Yeah, no, I think I agree with all of that, right? I mean, I do see there will be a huge financial impact for every health plan. Like Mark said, I think health plans have to take the lead here, assess how this is going to impact their bottom lines. They need to be ready with some kind of extra funding as far as, readiness for version 28 is concerned. Now, one of the things I can tell you is that Invent Health basically is really ready to help our clients and prospects out, right? Now, whether it's version 24, 28, or 32, or whatever comes later on, right? As a platform company, it is our responsibility that our architecture is designed in a way that we can adapt to dynamic business requirements and enabling us to accommodate any changes with the minimal effects and effort, right? For instance, we transitioned from V24 to 28 analysis and implementation in just 15 days. And in that case, even the client wasn't ready to utilize our outputs, right? So this reflects our deep understanding of CMS guidelines, state rules, and our commitment to staying ahead of the curve through ongoing R&D. It's simply what we do, right? So I think the healthcare industry needs more of platforms like ours where they can easily adapt to these changes going forward.
Thank you, Rohit. Well, that actually brings us to the end of the main part of our roundtable. It was a great roundtable. We have some real actionable insight for payers concerned about the V24 to V28 shift. Obviously, if you'd like to connect with Invent Health, please visit our website at inventhealth.com. With that, we are going to field some questions from the audience. If you have any questions, please enter them in the chat window, but we do have some that were pre-submitted here. But let's go ahead and take questions. So first question is for Siva. So Siva, how should providers update their problem lists and ensure the capture of chronic and complex conditions?
Great question in terms of what we are dealing with on a day-to-day basis, because it's process-wise, the providers and health plans need to work and already are engaged in order to know what are the active conditions the member has and how prospectively you can actually make sure the provider is educated about the conditions of the member so that they have a better outcome. The more important for you to look at is when new members are enrolled, what type of information you can pull from your MOR data as well as your MMR information to say how that is impacting your population, what risk conditions they have, how do you map it to both versions and associate them. Or even if you are doing a in-home assessments or some kind of a health risk assessments, that can give you a great insight to be able to track those members and enable them. One of the ways we help with health plans is to kind of create a prioritized target list for all the members with active conditions and keep reporting that information at the data at the point of care for the provider so that they can actually see what conditions the members have, how they can actually, what are the treatment or possible outcomes they need to track for those members. This helps both health plans and providers to be on the same page associated with the members and what to expect from a risk capture standpoint. Meeting the end goal outcome, basically, that will be the primary outcome. End goal is to have member satisfaction and the outcome, but risk score should be prioritized in the back end for the processing.
Gotcha. Thank you, Siva. So, Mark, what workflows need to be established or modified to improve provider plan collaboration under V28?
Yeah, this is an ongoing issue. I think that plans struggle with generally. I think it is going to be accelerated with the change to V28 because the amount of information and that needs to be communicated, particularly to provider groups, is pretty significant. It's, as I said, it's going to be accompanied with some impacts on revenue for these provider groups as well. And I think that, it is an opportunity, though, for the health plans to kind of work and improve their workflows with the providers. Information with the workflows that need to be need to be included in workflows, as Siva says, I think is really making sure that the problem lists are understood and addressed by the provider groups that the health plan is going to provide. And I think, that communication to make sure, one, that the communication of the changes and what the expectations about the needs that the provider groups need to make on their end. And then also on the back end, on the return, as data comes in from the provider groups, the plans need to be monitoring this to make sure that the changes that have been implemented because of the model are being adhered to and being addressed by the provider groups. Because it's one thing to educate and provide the information, but they're going to also need to make sure that they follow up with monitoring and auditing the data that's coming in, at least for 2025. I think an ongoing monitoring effort to understand how well your provider groups are addressing the changes.
Thank you, Mark. To close us up, Rohit, can you get us a little bit more detail about how Invent Health is actually helping health plans prepare for the V28 changes?
Yeah, I think I covered this earlier, Aaron. So I think it's a part of our architecture, right? So whether it is V24, 28, it doesn't matter to us. We are a platform company. And the way we have constructed our architecture is to take these changes one by one, right? So for us, we were first ready in 15 days. Like I said before, the first time any mandate like this hit us, 15 days, we were able to give the changes and the reports and outcomes to our clients. They were also not ready, and they were quite surprised with our outcomes, right? That was so quick and it was out of the box. So from an architectural business rule standpoint, we are always ready to take these changes. That's a part of our business, and that's what we do.
Fantastic. Well, I appreciate that. It does not appear that we have any additional questions at this time. So we'll go ahead and wrap up our November roundtable. I'd like to thank our speakers. I would like to thank our attendees. And again, if you do have any questions, please do not hesitate to reach out to us, and wish everyone a great rest of the day.